So we've got a college volleyball player with bilateral patellar tendonitis. She's had these issues for about 2 months. They're getting worse. She's been going to the training room, and shockingly enough, she's not getting any better. So you know what the most important 5 questions are in your subjective. One of those questions are, what have you been doing for this? So when I ask her what her current treatment strategies are, she's telling me that going to the training room for stretching and corrective exercises and patellar taping, and they experimented with some inserts in her shoes because she supposedly has flat feet. Also needling, and E-stem, and ice and rest. And shockingly enough, over two months, she's not any better. She's probably actually worse. So we know that. Now I can educate her as to why those strategies don't work and what we're going to do instead. So second step after her subjective is to do a functional screen. So functional screen, gait's pretty normal. Single leg squat is pretty terrible on both sides, unstable, pain. And remember, single leg squat, we're only doing not even a quarter squat. So it's a really shallow single leg squat, basically mimicking going down a stair. Okay, so she can't do that without pain. Double leg squat, she's got a lot of pain at 90. She seems to pass through it a little bit and has less pain at the bottom, but she still has pain at the bottom. If we look at trunk, so a little bit tight with toe touch, nothing great. Bilateral trunk rotation, good. Extension, good. Shoulder flexion, abduction, a little bit of pain on the dominant side, which is her right hand. But other than that, pretty unremarkable. Cervical spine is good. So put her on the table. So what are we thinking about here? What is the motion, or what is the joint angle that is causing her the most problem? Is it eccentrically, or is it during eccentric loading, or is it during concentric unloading? What muscles are responsible for stabilization in those positions? So remember, the screen isn't telling us jump on these muscles when we put her on the table. It's telling us these are probably the muscles that we're going to be finding inhibition in when we start going through our NFTs. So put her on the table, and what do you know? She's failing muscles that eccentrically control pronation. So vastus lateralis, glute med, glute min, TFL, soleus, abductor hallucis, transverse abdominis, glute max. So all that stuff in sections is failing bilaterally. Okay, not all of those things. So remember, if somebody comes in with Trendelenburg gait, don't jump on, oh, it's gluteus medius, we got to fix gluteus medius. It will never be one muscle by itself. If it's gluteus medius, it's probably also going to be several other muscles that are synergists of gluteus medius. And it might not be gluteus medius at all with Trendelenburg gait. It could be one of the other things, okay? So same goes here. We're not just going to jump on that side. We're not going to say, well, the left side was more symptomatic, so it's the left side and focus on that. We're going to say it was both sides. We need to assess both sides. And oh yeah, we also need to get to the trunk. And oh yeah, she's an upper extremity athlete who had a little bit of pain in the upper extremity that she's dominant with. So we probably got to look at that too. So we're going to go through all that stuff. Okay, so she fails pronation stabilizer, she fails transverse abdominis, she fails pyramidalis, she fails lat scapular stabes on the right, which totally makes sense with what we're talking about here. She fails with toe extensors, toe flexors, which is causing her instability in the feet, which leads right into the knee problem. So we're finding out what the problem is here. So now, as we go through and we reverse inhibition of those muscles, get her off the table, redo her screen, full depth squat, no pain. Single leg squat, good stability, no pain. Goes through functional movements that would be more sport specific, no pain. So that tells us that we did the right things. Now we give her exercises for home. We give her isometrics that are muscle specific to help maintain facilitation. We give her functional reinforcement exercises, which are full range of motion, aplanar range of motion with transverse plane components while she is loaded. We don't do anything laying down or on her hands and knees or in sideline. That's not how you play volleyball. Okay, so we give her those. So now we have muscles that are handing off from one muscle to the next muscle during eccentric loading, and we have muscles that are handing off from muscle to muscle as she's doing concentric unloading. So now we're reinforcing normal mechanics so she can return to play. So one of the questions on the story was, when can she return to play? And the options were when the MD releases her, which that's got nothing to do with anything. We're going to bypass the MD because they don't know anything about getting people back to play. They know about prescribing exercise and prescribing medication and doing surgery, which she doesn't need. When her brace has been fitted, she does not need a brace. They don't need braces. What was the other one? When she's totally pain-free, that's got nothing, pain has nothing to do with it. When she can pass a functional screen is much more important than when she's pain-free. I don't care about pain. If she's got pain, that means I still didn't get all my work done. I need to go back and look at something else. Okay, so the correct answer is when she passes the functional screen, she can go back to play, which should be after the first visit. So does that mean that her patellar tendonitis is gone? No. Does it mean that the swelling or irritation at the tendon is gone? No. What it means is the primary stabilizer, which is always muscle, is working, which will take pressure off of the secondary stabilizers. Secondary stabilizers are tendons, ligaments, fascia, all that stuff that's just connective tissue. Remember, muscle is the primary stabilizer. If it does its job, the secondary, tertiary stabilizers, which are connective tissues, don't have too much pressure put on them and they can heal. So now, even though the tissue has not completely healed and all the way back, we've taken the pressure off of it. So now it can heal while she's actually going to practice and doing things. So my patient education for her is go back to practice, go through warm-ups, go through all of your little drill things that you do at the beginning. If you have no problem, keep going. If you have a problem, take a step back, do the homework that I gave you, and then reassess. It's not, we're gonna take 3 to 4 weeks off, you're just not gonna do this. That's lazy, okay? It's not, well, when you feel better, then we'll try to do some stuff. That's lazy. Feeling better isn't the key. Okay, so she's going to go back to practice after the first visit, which she did. She came back to the office after a week of practice, practicing all the way through, no symptoms during practice, no symptoms after practice, and she got rid of all the crap that they were doing in the training room. I said, stay out of the training room. Tell them that whatever they did on the last visit they had with you was fantastic. It fixed everything. You're totally ready to go. Thanks. I'll see you guys later. Don't tell them that we did something else, and don't tell them that you're not doing what they gave you, because then they'll get all huffy and puffy and want to get you back in there, okay? So let me know your thoughts, questions. Try to get that done in 7 minutes. That was almost 7 minutes. So let me know if you like the faster pace, skimming the top. If you have questions about what I did more specific, post those below. Post if you want to have these more than once every 6 weeks, and post if you like the shorter 7 to 8 minute format versus the in-depth 14 to 15 minute format. See you guys later.